My opening lecture, which was the John F. Kurtzke Memorial Lecture, actually the first John F. Kurtzke Memorial Lecture, was on Do Relapses Really Matter? And they do. So, and that was the short answer to my presentation. We were honoring the late John Kurtzke, who we lost last year, who was a giant in the field and, amongst other things, was the author of the eponymous Kurtzke Expanded Disability Status Scale, which is the gold standard in clinical trials. My talk was about relapses because of late we have been spending a lot of time and effort, importantly, on progressive MS. Sometimes people forget that relapses are an important part of MS as well. They're especially important early in the disease course. They produce physical disability, they have emotional challenges, and they have economic consequences. Also, there's some interesting work relating early relapses to later progressive course. And even relapses during the progressive course can lead to a worse outcome. The therapies that we currently have for treating multiple sclerosis all actually treat the relapsing form of the disease. So it was a discussion to just highlight that this is an important aspect of multiple sclerosis. In some ways, it's a defining element of multiple sclerosis because we define it by episodes that disseminated in time and disseminated in space, and those are relapses. Relapsing forms of MS have been easier to treat than progressive forms. So our progressive therapeutic trials have all failed except for two. One with ocrelizumab, which has reported out a positive result, modest but positive. And another with biotin, but that was a small number and it needs to be enlarged upon. But we've had, a plethora of successful trials in relapsing remitting MS. And so that's where the attention's gone there because that's where the success has been. What's part of the overall MS picture? The misconception was that maybe they don't matter. And they do matter. They can leave residual deficits, and they can cause permanent impairment. We treat the acute attacks, if they're severe, with high doses of corticosteroids. The data aren't great, but anecdotally everyone does it and it seems to have an effect. It would be nice to have more science wrapped around how we treat acute relapses. It turns out it's hard to do the studies. Not that they're necessarily hard to treat, it's hard to do proper studies. The problem is we use corticosteroids and no one has an interest in corticosteroids because they've been around forever, so there's no sponsor that wants to pay for a trial of corticosteroids. If we had newer agents to take the place of corticosteroids, then that might be of interest. Like I said, some years back there were a couple of agents that were tested, both of which failed. So if we can get some new molecules and someone is interested in supporting it, we could theoretically do better. We have 14 marketed agents here in the United States. The 14th came on the market last week. There's more in the pipeline. I don't know that we'll find agents that do much better efficacy-wise. We're doing very well. We could do better, but that's a challenge. But we want to improve on the safety as well. Well, there's still a lot of people on interferons. We personally have not been starting many people on interferon. We've started still some with glutathione acetate, another old agent. And that's mostly individuals who come in and when we start talking about the therapy say, well, how long has that therapy been around? And there's some people who correctly worry about safety of some of the newer agents. They want more people to be exposed before they jump in. And those are people who may go on to glutathione acetate or less likely interferon. But we have a lot of people who are on interferon who have done just terrific, and we offer them the transition to oral agents. Some say, yeah, that sounds like a good idea because I don't want to inject myself anymore. But many say, I'm doing great, why would I mess with success? And it's a reasonable answer. We're at the point where they can manage it indefinitely. We're not at the point where we have cures or therapies that are so good that we can say, take this and don't come back and see me again. That we're not at. The goal, of course, is better therapies. The goal is a cure. Cure, when it happens, it'll surprise me. So I don't think it's necessarily methodical. It'll be some sort of major breakthrough. Right now, we are iteratively improving on what we're doing, and that's very comforting. The lesson for all of MS care, to all of the individuals involved, is that this is comprehensive care. And this meeting kind of highlights the issue of comprehensive care with physicians and nurse practitioners and nurses and physical therapists and occupational therapists. And the social workers aren't here, but they're a part of the team as well. And best care for MS is through comprehensive care. And that's what this meeting fosters.